Welcome to Podium Perspectives, powered by Vaniam Group.
Welcome, everyone, to Podium Perspectives, Advances in the Treatment of Gynecologic Cancers, SGO Highlights, a podcast that shares up-to-date insights across oncology and rare diseases. I'm Rob Coleman. I'm the Chief Medical Officer at Vaniam Group and also a GYN oncologist at Texas Oncology. And I'm excited to be part of this podcast series along with my good friend, Dr. Kathleen Moore, who is now at the University of Nebraska Medical Center in Omaha, Nebraska. Katie?
There. Happy to be here. Lots of exciting data we saw last week at Society of Gyn-Onc, so excited to break some of it down with you.
Excellent. Thank you so much. So let's dive in. We had kind of a nice late breaking session that started off the conference. I thought was pretty strong, and one of the first updates that we saw was the kind of final overall survival data from the Rosella trial, which of course was looking at weekly nab-paclitaxel versus weekly nab-paclitaxel plus a glucocorticoid receptor antagonist called relacorilant. And we've seen various iterations of this over time. One of which was an early report demonstrating a PFS and what looked like a pretty impressive overall survival signal, although it was as an interim analysis. And so we were highly anticipating the overall survival data to come out and proved itself to be positive. And of course, we found out by like what we see oftentimes by press release that there was a significant difference in overall survival that was found in the trial, and that was obviously very important. But today, and we saw the simultaneous publication today, or at the meeting with the final data. So, I guess maybe tell us a little about why this is important in the ovarian cancer community.
Sure. And so agree. I'm glad we're starting with this one because this was, I think, one of the highlights of the meeting for sure. In general, let's just start by putting this in context to the history and the treatment of patients whose tumors are designated as resistant to platinum. Our one success was the Aurelia trial, which was chemotherapy with bevacizumab, published in like 2014 or 15,
right,
and approved by the FDA and the European authorities based on progression-free survival plus supporting patient-reported outcomes, mainly around abdominal symptom improvement, but not OS, which will forever shock me that there wasn't an OS given the degree of PFS advantage. But that was our only success for a decade, and not for lack of trying, just a myriad of well-designed studies that didn't work. And then starting in 2024 with Mirasol, and then now we're here with Rosella, we've had 3 clinical trials with, I would say, modest improvements in both progression-free and overall survival, which puts us in a very different space for patients than we were 2 years ago. We now have several what we expect to be effective regimens for patients with resistant tumors, where prior to this we really had one, and it gives us the opportunity to really individualize for patients, think about sequencing in a rational way, in a science-driven way, especially with the additional drugs that are coming after this, and we'll talk about those. And I think provides our patients with some rays of hope, that we are going to push out how long they can live with these therapies. So just in general, this is important for that reason. Like, we have not had enough wins for our patients in this space, and we just are really on fire right now with medications that are pushing things forward. So that's my first statement. My second statement would be, this is a nice approval because PFS OS, the OS advantage is kind of in the same range as Mirasol. We're talking now about 35%. Mirasol was a 33% reduction in the rate of death for patients randomized to nab-paclitaxel relacorilant as compared to nab-paclitaxel alone. And it's also worth noting that nab-paclitaxel performed, in my mind, equivalently to weekly paclitaxel, so it wasn't an underperforming control arm error. It really did just work. And I think that's quite important and not biomarker gated. So while we
Right.
continue to try and develop things so we can really individualize for patients with biomarkers, some tumors don't have biomarkers, or maybe not as many as we would like. And this gives us
Mm,
an all-comer opportunity with the expectation of benefit. So, I think this was really noteworthy for those two main reasons.
sure. Sure. Yeah. And of course, this, you and I both have seen the kind of the landscape evolve with the recognition of how important weekly back taxanes have been for the backbones of these regimens. But in this particular trial, we used nab-paclitaxel. And why was that of interest, at least with this particular drug?
Yeah, so relacorilant is a glucocorticoid receptor antagonist. And the science is kind of beyond the scope of this podcast, but
Hmm.
you're and my good friend Dr. Neil Sud's been working on this for, I don't know, well over a decade.
Yeah,
Um,
15 years. Yeah.
yeah, 15 years. So we've been hearing about this, the preclinical work and the
Hmm.
hope of targeting glucocorticoid receptors, which are overexpressed on a number of tumors, but particularly on ovarian cancer, and even with physiologic doses of steroids, when you have that overexpression, and certainly in sort of stress settings like cancer, where there's an abundance of circulating steroids, and you have these excess receptors, it upregulates anti-apoptotic pathways that
Hmm.
in and of themselves help tumors be resistant to a lot of chemotherapies, but preclinically, the combination with taxanes looked the strongest for
Yeah.
potential additivity. And so we've been hearing about the promise of this for a long time, but it's just a really hard receptor to drug.
Hmm.
And so relacorilant is really the first effective and tolerable being a key
Hmm.
point, um, glucocorticoid receptor antagonist. And so keeping that in mind, if I'm trying to antagonize an abundance of glucocorticoid receptors, I don't want excess ligand circulating in the way of
Yeah.
exogenous steroids. So when we use weekly paclitaxel, we probably use too much steroids, let's just acknowledge, but we do pre-medicate
Yeah.
with pretty high
So-
doses of steroids. And so
yeah.
there is the theoretical risk that you could confound the efficacy of this medication, with that
Hmm.
on board. So with nab-paclitaxel, you don't need to use the pre-medications because there's
Hmm.
not cremophore, which is
Right.
what really drives our use of the steroids. And so that that helps us
Yeah.
um,
Yeah.
use a taxane without confounding the efficacy with a steroid. And probably just
Yeah.
better in general. Honestly, we use so much steroids on our patients, it's probably just better for that reason
Overkill.
too.
Yeah.
Yeah.
Yeah. Yeah. We even got in the weekly format. We even got used to reducing those steroids because it's every week they would get a lot of steroids with it. So yeah, I think I agree with you. I think this is an important milestone for us to hit. Third trial with an OS benefit in a very difficult to treat space. So that's great. We'll see as this continues to evolve. Obviously, there's some new combinations that are coming with that regimen, and we'll see how it goes forward. Let's switch gears a little bit. Also in that session, we saw a report on a very highly anticipated trial. You and I have been watching for this for a long time on GY019, which was actually looking at a endocrine strategy for low-grade serous. And maybe first of all, I'll ask you is, how low-grade serous and high-grade serous, they both have a lot of the same terms, but obviously they're very different diseases. And um, maybe we can start talk a little bit about just the biology differences. But in this trial, we had continuously seen endocrine therapy being used in the recurrent setting, and this was a frontline trial that was set up to address a kind of a standard approach, which in and of itself hasn't actually been proven. It was obviously chosen by the totality of data looking at chemo followed by endocrine maintenance. That was never actually formally assessed in a frontline in a phase 3 setting, but it was felt to be a good standard to follow. And then that up against a pure endocrine, which was letrozole alone, both given till progression. And this was a trial that was set up to address whether or not the new endocrine therapy was non-inferior. And so a lot of stuff to unpack in this particular concept design. But maybe we just start with a brief kind of reminder of why low grade and high grade serous are different diseases, even though they have a lot of the same terminologies.
Yeah. So it's really, Rachel Grisham also presented at SGO. I don't know if we're going to be
Yeah.
able to talk about RAMP 201, but there was a
Hmm.
lot of, I think there's just a lot of growing excitement around low-grade serous finally, our patients that suffer with this disease finally having medications advanced for them in particular, not as just an add-on, to things in the past. So low-grade serous should have a different name from high-grade serous because I
I
think
agree with you.
it just needs like a different name. It's not, high-grade serous it has ubiquitous loss of TP53. We do not see that in low-grade serous. In fact, if you have a low-grade serous that has a TP53 mutation, could be a mixed, I guess, but it's not
Hmm.
low-grade serous.
Right. Right.
So those are very different. Like the high-grade serous is a fallopian tube cancer. Low-grade serous really can start in a variety of places, but it's starting in the ovary or sometimes the peritoneum. They are largely driven oncogenically by changes in the MAP kinase pathway. So KRAS being our most common mutation, but you can see NRAS, BRAF. You find ubiquitous estrogen receptor positivity. We don't even have to test for it really
Mhm.
anymore. And those are very different from high-grade serous, where KRAS mutations are incredibly uncommon. Not never. You'll find amplifications in high-grade serous because it's a copy number driven cancer, but mutations are really uncommon for KRAS and high-grade serous. You'll find estrogen receptors all the time, but they mean nothing.
All
Like they're not
right.
driving anything. They're just
That's
there
right.
for the ride. And
Yeah.
in low grade, they're targetable. So these are really different tumors, and the expectation of response to cytotoxic chemotherapies and endocrine therapies are opposite in each of these cancers from one another. And so really understanding that and starting to design studies and sequencing of studies for patients who have advanced recurrent low-grade serous is really critical.
Yeah, and that's great. It's a really nice context to put the framework for this trial, obviously we've evaluated several different types of drugs over the time period. It's a we would classify as a rare disease, and that's one of the reasons I like the idea of like renaming it something else so that it gets out of that confusion. But this particular trial was done is a non-inferiority design, and these are somewhat complicated just in general to understand how to interpret. They're also complicated in how to actually design. And what we did in this trial is we set up a margin that we were comfortable allowing to show what the hazard ratio that we would accept. And in this particular trial, because of the concern that maybe we would be putting patients at risk, we had built in these interim evaluations. And what we saw at this meeting from Amanda Nichols-Fader was a report on the second interim analysis. And maybe you could just maybe briefly tell us what they found as the outcome in this trial for progression-free survival.
Yeah, so what they found was number one, both groups, really did relatively well.
Well,
So that's kind of one thing to say. But what the kind of interim analysis two suggested is that the use of letrozole alone, as
hmm
compared to chemotherapy followed by letrozole, did not appear to be inferior. So
right,
not inferior, not
right.
non-inferior.
Not
Sorry, let
non-inferior,
me say it
right.
right. Not non-inferior. So we can't say it is inferior, but we
Right,
could not statistically rule out the probability that it's not non-inferior. And so it kind of
right.
crossed that boundary of futility that we talked about. And based on the statistical rules of the study, they made the decision, to release the results and sort of
Mhm.
call this futile.
Right. Yeah, I think that's a good way to say it. They're incredibly hard to interpret because so often these non-inferiority trials are, which tend to have to be pretty big to make
Right.
definitive statements, and many of them end up in that gray zone where where the point estimate is either above or below one, but the confidence interval is broad enough to separate across all the different distinguishing characteristics. So what we said is that the intent here was to show that the new regimen was not inferior to standard of care. and we reject that null hypothesis because it was above that, into the zone that was above the threshold for the non-inferior boundary. So, I think the way that Amanda stated during her presentation is that she said this was practice defining. So, what does that mean? I thought that was kind of a cool way to say it.
Well, I think that it was an important thing to say because,
Mhm.
for right or wrong, and I'm not here to throw stones, but the NCCN had listed letrozole as an alternative, in the
Mhm.
frontline setting, and there are many in the community who rely on the NCCN to sort of provide guidance on how to take care
Mhm.
of our patients in the best way possible. We want to give NCCN level care at least, and this is no longer, in my opinion, NCCN level appropriate care, and we should
Right.
stop doing it.
Yep.
Now, could there be issues with the trial design and we included patients with residual disease? Is this, if we had
Mhm.
done it all and completely resected, might it have been different? There's lots of, every time we do a trial, we're like, shoulda, woulda, coulda. I wish I had done it this way, but you design the
Mhm.
studies the way you design them, and you have to state the statistical endpoint. So
Mhm.
the practice definition right now the standard of care is starting with paclitaxel and carboplatin. And then, as you said, I mean, I guess we say that it's letrozole maintenance, although it was never proven in a phase
Yeah.
3 setting to be
Steady.
superior. We have data for paclitaxel, carboplatin, bevacizumab in this setting as well that looks kind of good. But I guess I would say practice defining in that we cannot drop the chemo.
Right. I think that's really good. Yeah, actually, I'll just give a little anecdote. Though I know we had tumor board, and there's a low grade patient on the who was on the schedule, and it she she was really wanting the hormones, and so we at the end of the tumor board, we're like, listen, we're gonna have to wait until we see the results of this trial so we can make a decision as to whether she should go on to chemo. But as it turned out, then we did see this, and so that's what our recommendation will be, as the chemotherapy followed by letrozole as the standard. That's great.
Yeah.
So let's just maybe walk into maybe some of the novel therapies that we saw presented at SGO. This meeting usually fills up, as many meetings do, fill up as we learn more about the therapies that we want to hopefully replace in all of our diseases. So endometrial, cervix, and ovarian cancer. We want to see the progress of new therapies coming in that might be able to be good candidates for phase 3 investigation. And we had some interesting updates. Maybe just briefly talk about that very interesting drug that targets the p53 mutation, which is obviously an uncommon, a rare potential finding for our patients, but it actually is a very selective mutation and basically an undruggable target. So, what did you think about that? The results out of the Pinnacle trial?
The Pinnacle trial. Yeah, so this is
Yeah.
I'm so the phase 1 was just published in the New England Journal of Medicine like
Hmm.
this month, or maybe just late March. So I would encourage our listeners to look at that. But Dr. Alison Schramm, who along with Dr. Katerina Dembrava have really led this trial development of Rezatapopt. In TP53Y22C mutated solid tumors, the signal from the phase 1 in ovary was quite strong. And so this is sort of the expanded cohort of patients with ovarian cancer with this rare TP53 hotspot mutation, which is present in about almost 4% of high-grade
Yeah, that's
serous
about right.
ovarian cancer. So it's,
Hmm.
we say this now, we want you to look at all of the, whatever NGS you're sending, go back and make sure you look and whether or not, what the TP53 mutation is. And if it's Y220C, we want that kind of called out, because this drug, I think, is coming in pretty hot. It's an oral
Hmm.
medication. There were multiple cohorts that were looked at. We looked at the ovarian cancer cohort here at the Society of Gynecologic Oncology. There were 63 patients. It was a pretty good number,
Hmm.
cohort. Still small numbers, but
Impressive.
for a rare tumor, that's a pretty nice numbers of patients. And, I'm looking right now at the waterfall plot. I know that you can't see it, but when I'm looking at this, there were only 1, 2, 3, 4, 5, 6, 7 of them who had tumor growth.
Mm-hmm.
And then
Yeah, it's
everybody else
impressive.
had some
Yeah.
gradation of tumor reduction, until you hit kind of the RECIST response rate, which was about 44%. And that held irrespective of prior therapy, which is something we're thinking about a lot now. Had they had prior bevacizumab, the response rate there was 44%. Had they had prior
Mhm.
PARP inhibitor, that's 38 patients, the response rate's 52%. FR alpha didn't really seem to impact the activity of this medication either. So pretty consistent efficacy across a number of prior exposures. And then median duration of response, which is a surrogate for PFS, is sitting right now about 8 months. So, so small numbers, this is always going to be small numbers because this is a rare tumor, but we have an oral medication with a pretty high likelihood of causing some tumor shrinkage for a clinically relevant, amount of time. And with a side effect profile, and this is where I think using some of our new tools, we talk a lot, Rob, about
Yeah.
PIRO CTCAE, because I'm just going to
Right.
say it looks pretty good from a what we look at standpoint, where the treatment emergent adverse events were very low grade, kind of nausea, fatigue, that are there and important, but low grade. Only a 5% discontinuation rate because of adverse events makes me think that patients on this medication were tolerating it, pretty well. But we need more, proof of that before we say, patients feel great on it. But I think this is really one of these things that it's a needle in the haystack. It's kind of like NTRK. If you find an NTRK, you're going to use larotrectinib.
Yeah.
If I find
Yeah.
TP53, I want to use hope I'm be able to use
Yeah.
Ravadapop. So
Yeah.
where I use it, how I use it, I think is what the next iteration of trials will be.
Yeah, yeah, it is nice to follow up on the theme of kind of individualization of therapy, which we're doing across, obviously, also the ADCs, which we saw some updates, and I certainly encourage people to check out the data as it emerges in the public domain from the SGO conference. So why don't we wrap this up, Katie? It was wonderful to have you on. I would love to do more of this. There's so much more to talk about. And so these go so fast, but so many cool things that we could do as part of this process. And I really want to thanks for listening for the podium in this podium perspectives. And I would say make sure you stay tuned for as more and more data become available. This I just want to say one disclaimer that this is an episode is for educational purposes only and is not medical advice. but having said that, wasn't that fun? Thanks
Exactly.
so much, Katie. It's
Thank you
so
for
great to be
having
with
me.
you.
Yeah.
You bet. It's great to
All
see you.
right.
Thank you. Take
Bye,
care, guys.
everyone.
Thanks for joining Podium Perspectives, powered by Vaniam Group. This episode is for educational purposes only and is not medical advice.